That's right, I'm a radiation oncologist at Genesis Care, and I'm also the director of our department at Macquarie University Hospital. And I'm going to talk about an electronic medical record that we devised ourselves in Genesis Care, and I wanted to use a clinical example to show how it has changed the way that we look at our practice. So as a bit of background, I'm going to talk about breast hypofractionation, and it was actually something that Verity Ahern spoke about this morning as well. So when we give radiotherapy, we give what's called a total dose of radiotherapy, and that's measured in grey. And grey is really a measurement of energy. So when we're treating someone with radiotherapy, we can treat them with anywhere from 4 grey up to around 78 grey. And we tend to give those radiation treatments in daily doses. We call them fractions. So in the definitive setting or the curative setting, we tend to give what we call conventionally fractionated radiotherapy, which is radiotherapy given at 2 grey per day. What we started to look at in different tumour sites, and especially in breast cancer in the 90s, was could we shorten the patient's overall treatment time and just give a little higher dose of radiotherapy every day. So this is a bit higher than 2 grey per day, and we call that hypofractionation. In breast cancer, we did studies, and a Cochrane review actually showed that there was no difference in local control for those women that had undergone hypofractionated radiotherapy for breast cancer. The next thing that we look at when we're treating someone for any cancer, but especially in breast cancer, is cosmesis, or what does the breast look like after we've given radiotherapy. And we do tend to get concerned when we're giving higher doses of radiotherapy that are we actually affecting things like edema of the breast, the skin. And this UK study actually found that there was even perhaps a little bit of better cosmesis with the hypofractionated regimen. So therefore, Cancer Australia, as well as other groups, have released guidelines suggesting that we should consider hypofractionated radiotherapy for breast cancer in those women over 50, who are most of the women in the trials, and those with early stage cancers. So no lymph nodes, obviously no metastases. So I work for Genesis Care. We're the largest provider of radiotherapy in Australia, UK and Spain. We have 30 centres in Australia, and globally we treat about 30,000 patients a year, and in Australia we treat around 20,000 patients. So we wanted to look at what was our breast hypofractionation rates here in Australia. So from the years of 2014 to 2016, one radiation oncologist extracted the data for women who had early stage breast cancer and radiotherapy. There was over 3,000 patients that were able to be analysed, and we looked at those ladies to see, well, what percentage of those had hypofractionated radiotherapy for their breast cancer. And what we found was that the rates of hypofractionation did actually increase over those years. And in 2016, interestingly, our Chief Medical Officer actually did a roadshow and talked about the need to consider hypofractionation for patients, and we saw that the number did actually go up. So it shows the benefit of education and discussion of guidelines. We did find, though, that there's some variation in practice. There was differences between different states, different departments, different radiation oncologists. And what we also found was that this is a labour-intensive process. So anyone out there who has done a retrospective review, like me, looking through medical records on a Friday evening or a Saturday morning, it takes a lot of hours. So for this and for many other reasons, we felt we need to have a better system for collecting our data. So around the time that we did this study, we thought, let's look and see what kind of software, what kind of programs we can use for collecting our data. So a group of 5, our IT innovations team, actually looked to see what was out there in the market, and we couldn't really find that system, that electronic medical record that could fulfil all our needs at that time and the needs of the future. So we designed our own. So we got together a team of 5 people, backgrounds such as healthcare, also backgrounds like finance, and people who weren't really sure what it was like to come into healthcare and work in IT and healthcare, and actually really found it's quite an exciting area to work in. It's a complex area, it's a difficult area, but they really felt that you can make a big difference in data in healthcare. So after travelling around Australia and talking to our oncologists, they designed what we call RO Portal. So RO Portal is our in-house data collection system. So this is here on the left. And as an oncologist, we've actually included this into our normal workflows. So we have found that often the best way to collect data is if it is part of the normal workflow. So when I prescribe radiotherapy for a patient, I actually have to input their TNM staging and their date of diagnosis. So that's a mandatory field. I can't move forward until it's done. And then once I've signed off their prescription, that data is then extracted and it's linked to our Mosaic system. And then we can actually analyse this data or look at this data real time. So here on the right is an example of some analysis of that data. So this program is called Tableau. Tableau is very readily available. A lot of business analytics departments use it. But what I can do is I can search by tumour site, location, staging, and I can get data in real time. So this is August so this is just a snapshot of some of our centres through New South Wales, and I've searched those women with early stage breast cancer, and I've looked at the hypofractionation rate. So because we use this data to do our prescription, to do our radiotherapy prescription, I know exactly how they were treated. And this is just breast cancer. We do this for every tumour site. So what's the outcomes of all of this? Well, and it's really encouraging to hear people talk today. So we do have a system and we are utilising that system. We're getting very good data from that system, but we've still got a long way to go. And it seems that the more data we collect, the more we need to collect. And the issue really is collecting the right data for the right patient at the right time. And that's what we're working on at the moment. So currently we're looking at how we can input even more data into RO Portal, and automation is really is something that we really want to look at. So is there artificial intelligence that we can use to be able to extract data from PDF documents? Do we employ more staff to input data? And then what about patient-reported outcomes? Are there applications or software where patients can actually input their own data, and conversely they can get information from us about scheduling and timing of appointments? And then there's the linking with partnerships. So how can we share our data and get data from places like the National Death Index and Registry of Births, Deaths and Marriages? So we've certainly got a long way to go, and it's very encouraging to be here and to hear about other people, and I'm looking forward to a future where we are collecting data with the patient at the forefront of what we're doing. Thank you.
Thanks, Chelsea. That's a really fascinating presentation. Are there any questions for Chelsea?
Yeah, hi Chelsea, great presentation. My name's Matt and I work at the Cancer Institute. Just wondering, why do you put your diagnosis and staging into your RO portal rather than Mosaic directly?
Yeah, so good question, because Mosaic definitely has that, and we have used that in the past. Because the workflow we just found was easier, so you can do all of those functions in Mosaic as assessments, and you can do a prescription, but the way that RO Portal is, I think just the number of clicks, it's just quite a streamlined, quick process.
And a quick follow-up question, when you transfer that data across into Mosaic, does it just go into a note or does it go into the database and can be re-extracted and reported on out of Mosaic?
It can be reported on through Mosaic. So the two talk to each other.
Mine's very similar. Thank you for the talk. I'm Graham from La Rochelle Haven. Yeah, I'm just wondering, do you guys prescribe in Mosaic then as well? If your program does dump into Mosaic, do you prescribe from Mosaic or do you prescribe from the software on the front?
We prescribe from RO Portal, but it still comes up in Mosaic. So I think, and this is probably where you might have to ask someone from IT, but even when I'm treating a patient, I can still see on Mosaic their prescription, the number of fractions they've already had, the dose that they've already had. So there is that sort of back of Mosaic kind of integration.
Okay, so it sits on your D&I screen in Mosaic?
Good question, and I haven't looked because I just use RO Portal.
Okay, cool. Thanks.
I should check. Thank you.